kind of keeping it separate because we knew that neuroretinitis is not seen in cases of demyelinating optic neuritis or demyelinating involvement. So that is why it was kind of kept separate, and more likely either it was idiopathic, probably because we didn't know what is the possible etiology, and the other infections. Classically, again, conventionally we were dividing optic neuritis into typical and atypical, and this consideration or this thought was based on the landmark ONTT trials that were done. So the way they described what optic neuritis at that time, the understanding was that it was uniocular, it was predominantly affecting females in the young middle 20 to 50 year age group, mildly painful loss of vision over hours to days. The loss of vision could be subtle. Could patients come with 6/6 vision with just a little field effect or a quality deterioration like color desaturation, to complete. Virtually no PL has also been reported, although again, less likely to be demyelinating. Vision loss peaks by 2 weeks, 2 to 3 weeks, and then it levels off, and thereafter it starts improving. In unilateral cases, which is the typical presentation, there would of course be a relative afferent pupillary defect. You do not see a pupillary RAPD in a unilateral subnormal vision presentation. Do not think of optic neuritis. And as I said, the fundus could be anything from normal to papillitis. Various causes have been ascribed. Like I said, the most common at that time was multiple sclerosis, and now we've been talking about NMO. And of course, infections could present with a presentation similar to typical optic neuritis, and occasionally, especially in children, post-vaccination. Most of the causes are idiopathic in nature. And optic neuritis with MS, and at that time when the ONTT trials were going on, MS was the single most worry that people used to have. So it was seen that it would be present. Optic neuritis as a part of MS was present in 50% of the patients, and the presenting feature as optic neuritis for patients who eventually went on to develop multiple sclerosis was almost 20%. And recurrences, of course, were seen in the same in the fellow eye. Now, what now our understanding of atypical optic neuritis is? So atypical optic neuritis is, in a way saying anything that is not typical. So you would have a sudden loss of vision, immediate or hours. So immediate, think ischemia. A few hours, probably inflammation, especially around the nerve. It's usually over a day or two, the patient will definitely tell you the vision loss in typical optic neuritis. It may be painless or very severe. Both are not typical features. Older patients, bilateral involvement, severe disc edemas, a lot of hemorrhages, cotton wool spots. Vision loss progression or no improvement from up to 2 to 3 weeks. Think atypical. Recurrent episodes of optic neuritis, and like I said, no RAPD in a unilateral vision loss. Now, our understanding of the reason why we are classifying it as typical and atypical is just to give us a starting point to understand etiology. Typical optic neuritis presentation is more likely to be demyelinating in origin. Atypical optic neuritis is most likely not demyelinating in origin. It does not mean that demyelinating optic neuritis cannot present atypically. In children, we do see it appearing bilaterally, and anything can happen. But likelihood, so it's giving us a starting point of what we think the cause may be. So typical idiopathic, MS-associated, isolated, CIN. In atypical optic neuritis, you have a whole lot of possibilities, so our workup for atypical starts becoming more extensive. The diagnosis of optic neuritis essentially remains clinical, is based on the visual loss, the fundus presentation, the presence of RAPD, and of course the other visual functions, the visual evoked potential, and now we are using OC2 to a certain extent to help us, of course not in the diagnosis, but essentially to follow up the patient and help us to classify and understand the possible etiology. Again, no real investigation per se is required from a diagnostic standpoint. We still remain clinical in our appearance and our understanding, but baseline investigations like chest X-ray and electrolytes in an Indian setting would be essential, especially as you're planning to give IV steroids. The risk of a tuberculosis flaring up or, of course, electrolyte imbalances would be there. In atypical, of course, again, the key thing is to rule out infective, inflammatory, compressive causes. MRI, the next step has now become the most important diagnostic investigation that we are going to order. It was important even in the times of ONTT, but now with our better and better understanding of the MRI features of the various subtypes of optic neuritis, MRI has now become a key. I would say, if possible, do an MRI brain and orbits with contrast in all patients you are suspecting to have optic neuritis. It is the amount of information when we add it to the clinical presentation is phenomenal. We are actually started deciding which way the patient is going to move. But of course, it becomes mandatory in recurrent optic neuritis, patients keen to know about long-term prognosis, patients with history or evidence of other neurological involvement, atypical cases, and in acute optic neuritis in children. So if you suspect, so these are various protocols, but the moment you're presented or suspected with optic neuritis, your protocol becomes T2 weighted with flare with gadolinium contrast. So MRI brain and orbits with this definition, or I mean, most radiologists would understand an MS protocol. It's as simple as that, an MS protocol. A spine becomes important if the patient has symptoms related to spine. Of course, again, if you talk to a neurologist, he'll say spine must first go. But as ophthalmologists, we're always thinking of cutting corners as far as funds and patients' expenses are concerned. So I would say theoretically, yes, it's important. But if you're suspecting NMO, or if you have a patient with history of spinal problems, any neurological weakness, tingling of the lower limbs or anything, then yes, it becomes essential. Like I said, MRI for optic neuritis, of course, ONTT told us it is the strongest predictor for a likelihood of developing multiple sclerosis in the long term. And there are classical features that have been described for periventricular plaques, of course, the optic nerve enhancement. So these are very clear features that help us whether it's optic neuritis or MS related or not. Treatment, we know that methylprednisolone 1 gram for 3 days has now become the sheet anchor of treatment. 3 to 5 days, we've moved on. If you're suspecting that there may be a likelihood of NMO, we even give it to 5 days. Alternatively, dexamethasone we were using, but now again, because our worry of NMO and our fear of NMO, we have, and of course now the easy availability of methylprednisolone and not so much cost, we have moved on to actually sticking with methylprednisolone. Now, just a word about long-term problems or how we can defer multiple sclerosis. Once you're sure it's a demyelinating optic neuritis, we have a whole lot of disease-modifying agents that have known to reduce the relapse rate of optic neuritis, of any neuritis or neurological symptom in the long run. So, of course, as ophthalmologists, we do not prescribe these disease-modifying agents, but you need to work with your neurologist to consider and plan for long-term prevention of the patient developing multiple sclerosis. In India, again, this is just a background history. In India, in the first decade of this century, we constantly were concerned, and entire Asia was concerned, that somehow our patients are not kind of conforming to the typical view which ONTT has described for optic neuritis, and our patients were having a higher incidence of papillitis, bilaterality was more common, painless vision loss was there. Final visual outcomes were nowhere near what ONTT was talking about. They were saying 90% plus having 6/9 or better, and we were just not having that experience. We didn't find so many brain lesions, and somehow MS was not such a common feature in our patients. So, of course, we had this clinical profile again. When we compared, we found that Asia per se was definitely leaning away from the classical picture presented by ONTT. And over time, the last 2 decades, our understanding has, we have understood that things have come, that we face or we have a more likelihood of an NMO related optic neuritis, which is in presentation and long-term prognosis different from multiple sclerosis. In fact, a couple of studies have shown in India that 10 to 20% of patients who present with a feature of multiple sclerosis actually are NMO positive. So NMO positive antibodies are present in at least 10% of them. So that's how our understanding and our management and intervention of optic neuritis in India and Asia has changed. There's higher visual impairment, poor recovery, and more severe and significant involvement of the spinal cord. So NMO, the importance is bilaterality, recurrent, profound loss, poor recovery. So these are all changes. Lekhi Pandit, an outstanding piece of work she has been doing on NMO. And it's important, again, like I said, the importance of MRI, you're able to pick up a different involvement of the brain in NMO as compared to multiple sclerosis. So you have a totally different set of lesions more often than not that are seen in the hypothalamus, the brainstem, and these are areas that are, if you have involvement of these areas on the MRI, you start thinking of NMO, and it's very important to early think of this because your management starts becoming different. Your initial management remains the same. You give high dose methylprednisolone like you would give for optic neuritis, MS related, but we tend to go on for at least 5 days. If the patient does not improve, you may actually have to discuss with the neurologist and talk about plasma exchange. So it becomes an important intervention. We've seen that patients who are, this intervention has shown to have better visual outcomes over the long term. And of course, you remember that for prevention of further attacks in NMO, immunosuppressive therapy has to be used. Disease-modifying agents that are beneficial for preventing development of multiple sclerosis in the long term are actually contraindicated and have resulted in poor long-term prognosis in patients in NMO. So the other antibodies that have recently come out and our understanding is gradually developing is anti-MOG. So MOG is another variant of optic neuritis that we are seeing. You have a presentation which may be similar to optic neuritis, but recurrences are more. And although, again, initial management is the same, our understanding of long-term outcomes, which are better in MOG-associated optic neuritis, are still developing. So these are differences that you see on an MRI, and this is how you understand or your first impression. So if you do an MRI, you find you're able to kind of understand which of this you are landing into. The moment you think that it is not this, if it's clearly this, sure, go ahead and treat as an MS patient. If it is not this, there are no MRI changes or there are anything suggestive of this, go ahead and get an NMO mock test, because earlier you get to know, the better it is for the long term. This is just a pictorial description of the MRI changes that you actually get to see in the various types of optic neuritis. So just to sum up, optic neuritis typical features: IV steroids improve, follow-up. No significant improvements or steroid dependence, and you're seeing that it improves at the moment you stop steroids, the vision comes down. Revisit history, clinical examination, start thinking of NMO, MOG, get there. Sample blood testing, serology markers done, CSF analysis, or if the patient presents with atypical features, you come straight here, start thinking of other causes of optic neuritis, and of course the management becomes tailored depending on what you're thinking. As I've discussed, there are a lot of options for each, but as an ophthalmologist, our key understanding is what are we thinking in the first go, because it's the initial intervention that is really affecting long-term prognosis. So optic neuritis can be a part of MS. Atypical features, think NMO, MOG, baseline MRI essential, steroid speed recovery, but you may need to do a long-term understanding of the disease profile. Thank you very much. I just invite you to the INOS that will be held in New Delhi on 26-27 November. So hopefully with this attention, we may have a better and a very interesting neuro-ophthalmology conference. Thank you very much.
Thank you, sir, for that wonderful talk on optic